So let's just have a look at some of the evidence. So we've got a range of case studies on our website that are accessible to you that cover respiratory models. So I'd really encourage you to have a look at those. And then there's some published evidence as well. So we've got the reference on the bottom of the slide there. Really compelling evidence to support introducing group clinics. So how do group clinics improve access and quality? So all of the evidence that we see tells us that there are significant time savings available for clinicians, up to 80%, for example, for some topics. In relation to respiratory models, then we have evidence to say that there are fewer exacerbations, so reduced hospital visits for children, for example. Increased self-efficacy, so patients really taking control of their asthma or other respiratory type illness, so that they're really understanding what they can do to help themselves. Group clinics can really support the switch to CFC-free medication, and also gives you the opportunity to make sure that inhaler technique is correct. Group clinics really support the workforce development and staff wellbeing. We hear again and again from staff, from teams that are working with group clinics, that they really enjoy this way of working. One nurse said to us a while ago, "This has brought joy back to my practice." And then you're working with patients to co-produce their care plans. So they are inherently involved in that care plan. And that's got to be a good thing. Patients really being aware of what will work well for them, and they've had a say in creating that care plan. So I'm going to bring our speakers in now. So first of all, I'm going to welcome Holly and Hayley, who I am hoping are here.
We are here.
Lovely, thank you. Lovely. So
we're in the same room though, so Hayley's going to stay on mute until she talks, and vice versa, because there's feedback otherwise.
Perfect. I'm going to take the slides down, Holly, and I'm going to spotlight you so that we can all see you nicely.
Oh, amazing.
Lovely for you. Yeah. Thanks, Holly. Thanks.
We started our group consults in the end of 2022, so we've been doing them for a couple of years now, and we started with asthma because we had to see it was a stipulation of QOF that we had to see the patients face to face, and we had the IIF change of inhalers target, which on our 1,000 strong asthma register, we thought it would just be impossible to do in. I think they were having 20-minute face-to-face individually originally, and we just didn't have capacity to do it. So we had some training from Georgina, and we got all of our nurses trained. We got probably 4 facilitators trained, I think, and we decided to run a mixture of face-to-face and online sessions. So our online sessions, we tried to do sort of to coincide with lunch times at work, so that people could join on their lunch break. And then the face-to-face ones, we hired the church hall just a few doors down from us, and we did that there. We still do that there for face-to-face, and we provide refreshments, and just make it slightly more appealing to patients, because they were, and our staff actually were, really sceptical about it. I don't think anyone was really very keen to do it. But the staff helped design the process, which meant that they were much more on board with it. And Hayley she does the facilitation and the admin beforehand, but because she knows every aspect of it, what we did was, when patients were very sceptical about it and phoned up to say they refused to do a group consult, we put them through to Hayley, and she would sell it, and she always managed to sell it. And I don't think we've really got any patients now that refuse to do it. And now they're probably in their second year of having a review that way, so they know what it is and they expect it. But it would probably be a good idea to have somebody very enthusiastic about it in the practice that could talk to the patients, could talk to them about the benefits of it. And the same with staff, really. When you look at the 1,000 strong asthma register and think the staff are thinking we're never going to get through this, but then you say to them, well, actually, in a group session, you can see 15 patients and the facilitator will do the care plans afterwards and do some of the consultation in the notes, then it takes the pressure off them and they can see the benefits of it as well. We originally struggled with a very high DNA rate, but that's dropped off. We still do have DNAs, but it's not as bad now. And what we do is we overbook the sessions because we know that there are going to be some DNAs. And I think at the moment we're booking about 15 and probably, I don't know, maybe between 10 and 13 attend, which is manageable. We did have some very unmanageable sessions, which were a lot more than that. So we knocked it back a bit. But Hayley doing all the admin beforehand speaks to the patients, make sure we've got their ACT score, make sure we've got all their information. And our receptionists, they get a text message reminder and our receptionists ring them as well to remind them the day before, which I think has helped the DNA rate quite a lot. We use AccuRx to get their ACT score. So we send them the questionnaire, they complete that, and that goes straight into their notes for Hayley to record for the session for the results board. And we're just going to start doing AccuRx for Hayley to send out to the patients to get their postcode, their phone number, and their password. So that should reduce Hayley's admin time as well a bit. And we have had some really good feedback from patients. We've had some that has constructively meant that we've changed things slightly, but some of our feedback, we had one patient say, I didn't think I would like a group session, but I have to say I found it very helpful to hear about others and how they manage their symptoms. We've had someone say, I learned about triggers and how to respond and react in an asthma attack. It was very informative. I learned a lot. I feel more confident about asthma control now, and it was a learning experience. And it is quite obvious from the patient's feedback and when they speak to Hayley that in the sessions that they enjoy the group element of it. I think straight out of COVID as well, it was quite good because seeing people again was a bit of a novelty, and I think people were pleased to be able to see people. They also get a lot longer with the clinician, so they're there for about an hour-ish for the bigger groups, which is much better for them. They all do their inhaler techniques with the clinician. They get a one-to-one asthma review as well. And some of the other comments were, they said, I preferred this to a one-to-one appointment. The group setting was very comfortable. I felt listened to and cared about. I got more information direct from the nurse without feeling under time pressure like you do in a one-to-one appointment. So I think, and we've also had, we don't use it so much anymore because we've been doing this a long time, so we don't sort of tend to need it so much now, but we set up initially a staff WhatsApp group for the group consults with the nurses, the facilitators, and me and one of the doctors that led the project. And that was really good because we could sort of give each other tips, and they put some of the patients' feedback on there because a couple of our staff really didn't want to do it to begin with. It was a bit out of their comfort zone. And yeah, one of the nurses put on the group chat, and I think that nurse was one that wasn't very keen. They put a good group today. They were chatting between themselves, not offering each other advice. So I think then the staff can see the benefits of it as well. and we made sure that the staff, because we had 4 nurses, 2 of them did online and 2 did face-to-face, and we let them do that for quite a few months, and then we swapped them over so that they all were trained to do face-to-face and virtual, which was obviously good because if someone was off sick or was on holiday, then they could switch about, and they were all trained in it. So I think that was all that we had to say. Did you want to say anything, Hayley, about any of the admin side of it?
Just before you go, Holly, can I just ask
on.
a question? Can I just
Yeah.
ask, do you know now what percentage approximately of your asthma reviews you're doing as group reviews now?
We do all of our children face to face. With anybody under 18 doesn't get invited to a group consult. But I would say probably, Hayley, what do you reckon? A couple just here and there get booked in as face to face individual. Yeah, so we keep it to a real minimum. The asthmatics that have got COPD as well, they don't get a group consult. They get a face-to-face individual because it's obviously a bit different. But I would say just 1 or 2 here and there that either can't make the times that we have the group consults, or just for very varying reasons they can't come. But it's few and far between, I'd say now.
Yeah, I just want to share with the audience that is mega impressive. You guys are so humble around what you've achieved here. You have absolutely embedded this and made it the default. And there's a little bit of discussion in the chat around the patient recruitment side.
I wasn't looking at the chat.
Yeah, no, don't worry. That's
okay.
My job.
Okay.
as your facilitator here, and you know, you have put in. There's a couple of things that really stand out, and it would be amazing, Hayley, when you speak in a moment, if you could just cover a little bit about what you say to the patients, what you found really works as arguments for the group, because it is a big issue, patient recruitment. There's no doubt about it. But what's interesting is now that the patients have experienced the group clinic, they're not saying to you, I want to go back to one-to-one. They're quite happy with sticking with the group because a lot of them are repeaters now, aren't they?
Yeah, they are. They've done it two or 3 times now. So the other thing I didn't mention actually, which I was going to, was we have expanded it now to we've done some statin group consults. We do our contraceptive group consults. So we do a group consult for all the education before you have a coil or an implant fitted or removed. So they do that all via group consult. And we do a dementia group consult, which is face to face in the church hall, and is more run sort of like a coffee morning with cakes and stuff. And we've had Hayley's organised them really well, and we've had outside agencies like Suffolk Family Carers, Alzheimer's Society, and various different groups that we've had come, and patients come with their carers, and it's been really well received. So the group consult model has sort of snowballed onto other things as well. I don't think it would be long before we look at our diabetics, but that's just slightly more complicated.
It'll be really good for you guys to try this and do this in diabetes. I've got a couple of tips as well on that, which I'll pop into the chat around how you might be able to increase funding as well, related to diabetes. So I'll share that in a minute. So shall we hear quickly from Hayley? And Hayley, just to give you a little bit of a framework here, people are really interested to hear what you say to the patients. And the words that you use and the sort of arguments that you use, but also the times that you have your group clinics as well. So if you can make sure you cover those 2, but it's amazing to have you here as clearly a bit of a linchpin in making this work.
Thank you. So it's been a while since I've had to have a conversation with the patient about sort of selling the group consults, really, because most of them have been now. But initially, people were reluctant to join. They didn't feel like discussing their medical condition in front of other patients was appropriate. So I just sort of would first of all, just say that, I'm Hayley. I'm the facilitator of the group consultations. I'm just want to sort of tell you about the group consultations, about the education side of it, that around 90% of patients that do attend do say that they've learned something from a group consultation. And those that are a bit more reluctant to come to the face-to-face groups, I sort of sell the online groups, because obviously they can, if they wish, keep their camera off, and then they don't feel, they're sort of quite as intrusive as the group consults that are face to face. They would ask questions about the group consults, and I would try and explain how they run. The only things that are discussed are that their asthma control test score, how many blue inhalers they will have had in the last 12 months, and their smoking status, and that their other medical conditions are not discussed, and what they choose to discuss other than their asthma is entirely up to them. I do mention that everything that is mentioned in the group is confidential, and patients are asked to consent to the patient confidentiality agreement.
I think the other thing Hayley does is when she speaks to them, Hayley's very, friendly and sort of builds up a bit of a relationship with them. And then she says to them that she will be there and she will see them there. And I think that puts people at ease, because they don't feel that they're sort of going to walk into a room with lots of strangers. There'll be somebody that they've spoken to there before. And I think that probably helps a lot of them.
I think that's a really, really good point, Holly. And also, I think the key thing for people to recognise is that this, as you said, Hayley, this is not a conversation you're continuing to have with people. Once they've experienced it, they actually are happy to come back. So it's part of the pain of change, isn't it? What about timings? What time do you run the sessions?
So we run the sessions for about an hour. I spend probably the first 10 to 15 minutes just running through the confidentiality agreement, how the session will run, what is expected of them, and then I pass it over to the clinician. They do the sort of the clinical side of it, the asthma review, and then at the end of the group, I will ask if they want to set any goals going forward, and make notes of those, and then I will add that to the consultation in the medical records. Once the clinician has done doing the review in the Ardens template, I will then go through and create a action care plan, asthma care plan for them, and then I send that to them either via AccuRx or by post if they haven't got the means to open it on a device at home.
Brilliant. So you are actually right. I know this is another really innovative thing that Burlington's done. I see so many different teams and how they're working. So I'm in a very privileged position to be able to pinpoint some of your unique best practice that you've implemented, Hayley. So just to share with the group that, the nurses don't need to write up the asthma care plans anymore. Just tell us a little bit more about that.
So once if there are any changes to be made to their inhalers, I will have a look in the records. But I'm also making notes during the group consultation anyway, so I do know everything that was said or if anything needs changing, and I car park that also. But once the clinician has finished adding their notes into the record, I then go in and will open the respiratory template, the Ardens template, and then create the action care plan through that. I will then look to see what inhalers have been changed, and I add those in, and then also add in the emergency care advice that we cover in the group, and then I send that to the patients. But if they have any questions or anything at the end of the group, then we also sort of car park those, and I'll try and find out and get back to them if they need to know anything else.
So I know that you've told me before, Holly, that that's saved almost as much nurse time as the group clinics.
Yeah, it's it does take a really big weight off them, I think, and it means that they can, they come back, they have a little bit of admin time, but then they can just crack on with their other clinics that they've got here.
Yeah, it's a brilliant model. It's actually a piece of best practice that could be applied to so many different pathways as well, not just asthma. So I think it's a really important one. Hayley, is there anything else you want to say before I hand over to Bev? And Bev, just to signal, we had a question in the chat around, sort of a little bit, how does the group clinic program, a group clinic run to cover off the asthma action plan and personalizing it with medication? So yeah, you are a regular speaker for us on this subject. If you wouldn't mind just weaving that into your talk from a clinical perspective, that'd be amazing. But Hayley, any other tips for people that you'd like to share, or just comments or reflections?
Not that I can think of, but I mean, I'm happy to take any questions or answer any questions at the end or whenever.
Brilliant. Did you tell us about what time you do the group clinics? I can't remember.
Oh, no, I didn't, did I? So we do the face-to-face ones in the morning, usually at the church up the road. And then we do the online ones, usually around lunchtime. I think Holly mentioned earlier about doing them at lunchtime so that people can attend in their lunch breaks. So it just makes it more accessible to people that are working.
Brilliant. I know when you first started off, you did quite early morning video ones as well, didn't
we
you?
did,
but found that
the
lunchtime
DNA rate was quite high for them, wasn't it? Because we started at 7:30, I think that was. We used our extended hours and did a 7:30 session in the morning. But it was a bit too early. We got a lot of people that said they overslept, didn't they? And just DNA.
Yeah,
so
your DNA rate was a bit higher on those groups.
Yeah,
but
we
the
dropped that one.
Lunchtime's working quite well for people, because that's what we often say. You can do them at lunchtime, so people who work join. So that's working quite well for you guys.
Yeah, and if we have teachers, Hayley has had some teachers that have said, "Oh, I just can't do it." So then Hayley points them towards one in the holidays, and we get them that way. So there's always something that suits most people.
Yeah, interesting. Cool. Okay, so you guys have absolutely cracked rolling this out. That's the message that I want people to understand. And actually, what you've done is you have followed a lot of the advice and best practice that we given you. And I think, Holly, you've shown real leadership of the team to sort of keep it going, keep everyone on track, keep everyone engaged, but also stick to your guns. We're not going back to one-to-one. We're going to make this our default. And as you can see, once you get over that pain of change, actually the patients are happy to come back. And also another thing that is really good to hear is that you've reduced the length of the group clinic a little bit, so you've made it about an hour now that you're all really mastering this way of working. So well done. Massive respect to you guys for making it work. We need to update your case study that we've got on our website to sort of embed all of this. So over to Bev now. So we're really lucky because we've got the whole team here today on this call. So Holly's a practice manager, Hayley's our facilitator, and Bev is going to give us a clinician's perspective now. So Bev, over to you.
Thank you. So I think it's fair to say that I usually start these sessions by telling people that I was an absolute cynic when it came to the concept of shared medical appointments, and I absolutely could not understand how it was possible to personalised care when you had a whole group of people turning up together. And that's when I now look back and realise that I was thinking about group education rather than, these shared medical appointments, these group appointments. So I think once I realised that group education is about me standing at the front and teaching people about the condition that they've got, whereas what I was really trying to do was have a one-to-one consultation within a group setting, it made more sense. And it took a while for me to be convinced, but the more patient feedback I saw on areas like YouTube, the more convinced I became that I needed to put aside my doubts and actually give it a go. So I worked with Georgina to understand how the whole thing would work, how we'd initiate it. And then I actually started off with running some sessions for pre-diabetes, and then I moved on to diabetes, and then I moved on to asthma, then COPD, and I've recently done some chronic kidney disease sessions as well. And what I found was that all of the stuff that's already been mentioned was absolutely true. The time element is incredible from a clinician's point of view, to be able to see so many people. I mean, when I did the chronic kidney disease one, I brought in 14 people, and 12 of them went away on optimized medication or plans to optimize their medication for their chronic kidney disease. And that was all done in an hour, very effectively, with lots of questions and interaction with the group. And it really did strike me. And I was told afterwards by patients that they felt very able to ask questions that they maybe wouldn't have asked on a one-to-one. And it almost felt like they were legitimately able to ask questions that might have felt too challenging to me as a clinician, as in they would challenge what I was saying. They were able to do that in a group setting more than they would do in an individual setting. And I think that's quite powerful for patients to feel that they're able to do that, because there's quite a few of them. Not that we end up in, adversarial situations, but I think sometimes when you're talking about changes in treatment, and we do that a lot in respiratory, people can feel backed into a corner potentially if it's a one-to-one, whereas if there's a lot of them asking questions, then it feels a bit more even. And I think that's one of the key things with these, is that the power balance is very different. So with my asthma group consultation, I've done them myself in practice. And I've also been out to other practice to try and support them to understand why they might want to do it. And what I do with my respiratory is really interesting, hearing about the personalised asthma action plans, because what I do is slightly different. And I think that what that tells us is that you can tailor this to what works for you. So it's not about a one size fits all. It's not about everyone having to do things the same way. It's about finding the way that works for you, for your population. So timings for us, we do some in the morning, we do some at lunchtime, we do some in the afternoon, and we do some in the evening, by which I mean usually 5 till 6 is when we run our last session of the day. And that seems to work quite well, because people can come whether they're working or not without it sort of impacting on their evening. But the patients will come in, they'll have already, if we take asthma as an example, they'll have already done their asthma control test questionnaire. So we'll have an idea about the level of control that we've got. But I also will look at how many inhalers they've ordered. So I'm very much, and I'm the asthma lead for the Association of Respiratory Nurses, so I'm very much not about blue inhalers. We shouldn't be prescribing blue inhalers for the majority of patients now. So it's less about counting those and more about looking at how much of their preventative medication they're ordering, and whether it's in line with what I would expect, whether it's less or more than I would expect. So we look at that, and we look at whether people have had exacerbations, whether anybody's needed a course of prednisolone, which should be a never event, or even whether they've ended up in hospital. So we gather that sort of information. Everyone comes in, same as you've already heard, Q&A session, very relaxed, very enjoyable, I find that. And actually a lot of what goes on in the one-to-one consultations is covered in those conversations at the start. But when we get into the one-to-ones, I'm doing exactly as I would do in a one-to-one without the group around me. So covering the elements that need to be addressed for QOF, because obviously we have to tick those boxes, but also looking at the elements that we need to address from a personalised asthma management perspective. And that's where I finally got my head round, or did eventually get my head round, this idea that I can personalise the approach to the individual. So what I found in one particular session that I remember is one person, so this was the session that I did where I went in to help with a practice that wasn't my own, and they still had quite a few patients on a preventer inhaler and then a blue reliever inhaler, which is a bit old school these days. But the first patient that I went to speak to actually had a combination inhaler that had both preventer and reliever in them. And they were using that alone. So they were just using that, which is the new way of managing asthma. And so when we started talking about how they were using it, how often they were using it, how they relieved symptoms if they happened, how they used the device, so they demonstrated their inhaler technique. What happened then is that each subsequent consultation, people were saying, hang on a second, I really like this idea. Hello, can I actually get that sort of approach? Can I use that type of inhaler? Could I have one inhaler for everything instead of having to juggle different inhalers? And so bit by bit by bit, they were all taking on this idea of improving their asthma management, bringing it into the 21st century, but without me having to do one by one consultations, explaining the procedure, explaining the inhaler, demonstrating how it worked. It actually became something that translated into all of the individuals as I went round them. So they all demonstrate inhaler technique. They all bring their inhalers with them. So that's how we make sure that bit's done. They critique each other's inhaler technique, which is really powerful because sometimes it seems to have more welly when other patients say things compared to me saying things, of course. But when it comes to the personalised asthma action plans, what I do is I actually get them to do their own. So we sit there and they'll have a blank asthma action plan, so a hard copy. And as we go around, we talk about what asthma action plans should look like. I talk about, what does good asthma control feel like to you? What can you do? How do you know you're well controlled? How do you know when you're less well controlled? So it might be symptoms, it might be peak flow readings. There are different ways that people do this. And then my third question to them is, what do you do if you're less well controlled? So people are already thinking, they're hearing these conversations going on, and they're thinking about, what would I do? How would I change my management? What do I do with my inhalers and my doses of medication? So they're actually writing that down. And although I think it's a really lovely thing to have somebody doing it for them, I actually believe personally that getting them to write their own action plan can be a really positive experience. So I think that there are different ways, and I'm sure you probably save more time doing it the way you do it with Burlington, because it can take a bit longer with everyone doing them individually. But I suspect that it can be quite impactful to write your own personalised asthma action plans.
I think that's a really good point, Bev, because there's something about writing it down yourself I think behavioural science shows that if you actually write it down yourself, like, when people ring up for an appointment time, you should get them to write it down themselves, because then they're more likely to come, they're more likely to action what they've written in their own hand. So, but it just goes to show that there's no one solution, is there? Every practice can design their own group clinic, and a big message we hear from people is that the autonomy it gives clinicians to redesign. And I think you touched on that, Holly, as well, that it was because the clinicians were involved in the design of the group clinic that they came on board, that they became engaged, because it's your consultation, so you should actually be the one designing it. We've got a question from Lucy who said, how many patients do you typically have in a group clinic? So we've heard that from Burlington. What about you, Bev?
So yeah, very much the same. We overbook so that we know that we'll get enough people in there to, and in theory, if I would normally have done 20 minutes per consultation, as long as I've got 3 people in a session, then I'm already, online. Anything more than 3, and I'm moving ahead of the game. But we will often have, and I think you have to get used to this, and I wouldn't recommend starting this way, but we'll often have 10, 11, 12 patients in a group clinic, and that works for us. But we've been doing it for a while. People are used to it. They know what to expect. And also, I truly feel, and this goes across all of the conditions, I feel that it leads to better management. So actually, as time goes on, you get patients who are better managed, who are more stable in terms of their long-term condition. And so they perhaps become less challenging. I think when you start off, maybe go smaller, just to get a feel for it and build up your confidence. But by this stage of the game, we can do bigger groups and they're just as effective. And I remember being highly convinced by a rheumatologist from up north who was doing outpatient clinics with 30, 40, even 50 patients in, which is incredible. I mean, I wouldn't go down that route, but it was working for him.
Yeah, and it is. I mean, I think it's really validating for people listening in who are quite new to know it is. It is like I go cold water swimming, and when you first go in at sort of 10 degrees, you only stay in for a very short period of time, but then as you get more used to the water, you can be in there for 15 minutes. Do you know what I mean? It's the same thing, isn't it? You're actually the more you master this approach, the bigger the group you can work with, because that the issues that will come up are not going to, they're limited. There's a limited number of issues that people are going to raise. So that's really, really good. And I know that if I remember correctly, haven't you done COPD groups as well? I'm just aware of time. We're quite close to the end, but just give us a little feel so that we're not only talking asthma about the COPD and how that works.
COPD can work so well, and particularly if you've got patients who are, for example, not engaging with pulmonary rehab, which we know can be very powerful. There's 2 ways that we've tried to address that in our practice. So bringing them together for the consultation, where we've got people who've already completed pulmonary rehab who can be very persuasive when it comes to encouraging other people to attend. But also, we've been doing group consultations with people who are at a less severe end of the COPD spectrum, who are ready to do what they can to reduce how much worse their condition gets. And we know there are lots of interventions that we can do. So in a group where people have got quite severe COPD, the support, again, that they get from each other, reassurance about how helpful exercise can be and other elements of their care can be really powerful. But the other end of the spectrum, it can be great to get them in sooner and do a group clinic with people who are less symptomatic to talk about how we make sure that that remains the case. So I think, they work really, really well from peer support. We get people going out to park runs, but they walk. We get people talking about how diet can be affecting their COPD. There's so many elements that come up that you probably wouldn't cover in a one-to-one session because they bring them up.
Yeah, and just making the link to what's going on at the moment nationally with, the focus on prevention being so much more important. The group clinic model is creating the time to do that preventative work, that lifestyle work. It's been an amazing session today, and it's so brilliant to have the different perspectives from everybody.